without further ado, I am really excited to be introducing Tanissha Harrell and Rebekah Angove, who are going to be the moderators for our session. Turning it over to both of you right now.
Good morning. Can you hear me okay? Thumbs up. Can I get some reactions? Hello, everyone. My name is Tanissha Harrell. I am really excited to be here with Rebekah and the panelists, and we hope that this is an engaging conversation for you all. As you can see, I'm representing San Diego, California, with the cool breeze and palm trees in the background. Give you a little bit of aesthetics, and we just hope that you're in for a ride. And so, as Caroline pointed out, that and you pronounced my name correctly, by the way. I just wanted to let you know. Thank you. We are here to kind of, summarize, share points of perspectives around our intent that we initially had for the conference. And so I'm going to read these out, and I'm differently abled in terms that I have a loss of eyesight in my left eye. So you might see papers every now and then. Please forgive me for that. And so at this juncture, I will turn it over to Rebekah to introduce herself. And I am also the Director of Partner Engagement with 211 San Diego, the CIE team. Rebekah.
Thanks so much, T. This is Rebekah Angove, the co-facilitator, and I'll be doing a lot of monitoring of the chat. So I just want to remind everybody, if you have questions, put them in the Q&A. If you have comments, please put them in the chat. We're actively looking at that, and we will pull that into the conversation. I am the EVP of Research and Evaluation at Patient Advocate Foundation. I am also the director of our Patient Insight Institute. And I have been on the planning committee for this event. So I'm so excited to be here and see this 3-day event happen. It's been very, very rewarding. I just want to really highlight and set us up for the day a little bit. This, I think, is really one of the most important panels of the entire event. My career has been solely focused on incorporating the patient and caregiver perspective, those within communities and with lived experience, pulling those perspectives into policy, care, and research initiatives. And so I really feel like those that have lived experience, that are experts in that experience. I heard somebody say they have a PhD in the lived experience. I think these are the most important voices and reflections that we will hear in the entire event. So thanks for joining us today. T, thank you for being our fearless leader in this conversation. And I look forward to this next hour.
Awesome, thank you. So I'd like to introduce you to Mike McNear. Tell you a little bit about Mr. McNear. I have grown to call him Uncle Mike. Mike has lived experience as a caregiver for over 30 years for a parent with Alzheimer's disease while dealing with an immunosuppressant disease for over 20 years. And Mr. McNear currently resides in Atlanta, Georgia. Can we get some claps and hand shouts for Mr. McNear? Welcome. And then we also have Stephanie Walker with us. Living and thriving with metastatic breast cancer since July 2015. Advocating for equal and quality care for Black men and women living with MBC in rural and underserved areas, and a retired RN who has taken care of the most precious population, babies and geriatric, in critical care settings for over 40 years, and currently resides in Eastern North Carolina in a small community, rural bystanders. Can we give a shout out and welcome to Ms. Stephanie? And next we have Anne Reynoso. One sentence that describes Anne is that Anne was recently diagnosed with you guys are giving me interesting words to pronounce. Here we go. Lymphocytic intestinal pneumonia and pulmonary fibrosis 2.5 years ago, and currently resides in Texas. And did I pronounce that correctly? If not, I would love for you to add your voice and say it accurately if I didn't pronounce it correctly.
It's called lymphocytic interstitial pneumonia.
Thank you, Anne. That's a lot for a girl with a list. And next up, we have Lisa Hamlett, currently from Southern New Jersey. Whoop, whoop. Let me tell you a little bit about Miss Lisa. Pardon my panda is one of her favorite phrases in reference to the 22 animated film Turning Red. Some interests that Lisa has are she enjoys all types of music, going down to the shore, revelry of the arts, cycling, simple physics, a novice birder, sumo wrestling enthusiast, and an avid interest in cultural anthropology. Lisa has over 20 years experience in public education and 10 years in banking and finance. Can we welcome our panelists? Hello, hello, hello. Now, I need some of y'all to come. Yes, cultural anthropology, whoop, whoop. How are you guys doing today?
We're doing well. We are doing well.
Awesome.
Yes, we are.
Are you guys ready to share some perspective?
Yes.
Yes.
Lovely, lovely,
Yes.
lovely. So over these 3 days, we all got to experience various discussions. We got to experience different plenaries, learn different things. I know I've learned a lot. I've also been challenged. And I just like to kind of know from some of you, what has been most impactful and resonated with you thus far? And we'll just do a ping. We'll start with Miss Stephanie.
Oh, great. Put me on this. Put me on the spot. Well, I'm going to claim like chemo brain, but I have been really surprised. Today's sessions have been just talking about food insecurities. That, and sorry about the background noise. I'm going to apologize right now for that. That, you know, especially children in pediatric hospitals or in a hospital, I have seen where there is home or food insecurities. But like I was asking one of the researchers, apparently there's no follow-up when these kids go home. You know, in the hospital, they can order all the food in the world, you know, and they're going to get all the food in the world. But then they go home and they don't have that. So there's no follow-up. And knowing about the SNAP program, you know, yeah, a lot of Blacks do receive the SNAP programs, but apparently the cost or the price per meal hasn't gone up in months, Sundays, days, and years. And also, in speaking regarding another racial group, is the Asians obviously have huge food insecurities, but really low SNAP involvement. So that was very interesting. And coming from the medical background, you don't get a lot of the socioeconomic stuff in the hospital. You kind of like do your thing in the hospital and send them back to where they came from, per se. And sometimes that's not always a good thing to send them back to where they came from. So today's have been really, really enlightening. So
Thank you for sharing. Yes. Anyone else have anything to offer?
Yes, I would like to segue from Stephanie to Dr. Rhea Boyd and Dr. Osagie and Darren, Mr. Darren from Berkeley and Sanford. They did an incredible job in educating me to focus on how critical and serious this racial medical divide is in America, in the USA. I am one, and I'll put it out there right away, I am definitely for universal health care that would help to address a lot of the barriers that we are experiencing as a nation. We're one of the richest nations on the face of the earth. And yet we still are dealing with these medical divisions and divides and discrimination. And I can parallel it with my 30 years of caregiving to 30 plus years, really. I had a mother who passed roughly almost at 99 years old. And I had to sacrifice my scientific chemical career to provide care for my elderly mother dealing with dementia / Alzheimer's. And I found myself in that, being that I pursued a career, but yet I was looking for my real purpose. And my purpose was to be a servant to the dearest person in my life. And that was my mom. And now looking at this particular conference, I see why I was challenged with a lot of the social programs that I was denied or had to actually take my parents out of the system and bring them into my own home to provide care. And not only my mom, I had to do it for her brother as well. So I was moved by the transparency of Dr. Rhea Boyd and Dr. Osagie, the honesty and the boldness in how they presented the data and their material, and what steps we can take to move this discussion forward.
Thank you. Mr. McNair, are you an abolitionist?
Oh, absolutely. I am now.
Thank you for that. Thank you for that. Yes, I think there are many of us that can resonate with taking care of a loved one and how the system itself is designed to create more poverty in order to, have access to those services. I can totally identify with that. Miss Lisa or Miss Ann, do you have anything that you would like to share that is what's resonated with you? Some things that you've learned, some things that you would like to share? I know, Miss Lisa, yes, come on through.
Yeah, in piggybacking on what Mike was talking about, yes, I would have to say the trio for the education, that was very impactful for me, because I've worked in the public education system for about 20 years. And one of the most profound things was talking about abolishing the current education system. I agree wholeheartedly, because it's not working. And something needs to be done. It's a broken system, but also please keep in mind that although it's broken, some of the students, some of the children, that is the only place where they can get a hot meal and the only place where they get medical care. And when I tell you, it is to that extreme, to how some of these children, some of the environments that they are dwelling in or trying to survive in, it's as basic as that. So although I agree that, yeah, we do need a huge overhaul of our education system, and, have it complement with the healthcare, some healthcare terms for the school district would be really great. But yeah, I thought that was really good too.
Thank you. Thank you very much for sharing. Miss Ann? Oh, you're on mute.
I have so much noise in here, I forget that I have to mute myself all the time.
No worries. There's grace in this space. We all understand we're in mixed environments, so it is what it is. We'll basically want to hear you.
I just wanted to say what I took away from this conference. It's, first of all, it's been nice to be a part of a group with wonderful people, made some great friends. And I've learned a lot from a lot of the researchers here too. I learned that I finally am so glad that we are absolutely discussing and recognizing the inequalities and disparities in healthcare and social care, especially the biases. We've talked about food scarcity. We've talked about, racism, inequality. But this past, and most of you know, I'm a freelance writer. So I do write about, my healthcare and lived experiences for Bio News. And my previous, current article is about biases in weight within healthcare, and how a lot of minorities, especially in my culture, we battle with weight gain and how to lose weight and how to eat properly and healthy and nutritiously. But the problem with that is that a lot of us don't have the the means to provide ourselves with healthy foods. So I'm really glad that at least now we're trying to get these disparities and inequalities out there through research, and hopefully more people, more universities, more communities and more organizations will hear about this, and we can actually move forward, more with that and figure out what to do next. And Mike, I like your idea with the universal health care. I do like that.
Thank you, Ms. Ann. I also wanted to inquire, I'm curious in terms of, many of our presenters are from, social care research. And, in terms of like presenting findings and how that resonates with the community. And often some of the things that I hear from the community, and I also have experienced myself in participating in evidence-based research in terms of never really knowing what the outcomes were of that particular said research. In your interaction with the conference, is there anything that you would like to offer our social care researchers? What would be most helpful, in moving forward? And we understand that researchers don't always necessarily interact with said subjects. However, is there anything, from your insight that you've gained over these last three days that you would like to offer as an opportunity that would be more helpful, or what you would like to see more of? And I would, I'll go to Miss Lisa.
Oh,
and you
wow.
you can feel free to pass if you like. No,
Okay. Well, there's a lot of content. So I will try to answer as best as I possibly can.
Please do.
Okay. Well, the one thing that I could say about research, that one thing that I hope that there is understanding that who your subjects are, that your subjects are actually people, okay? That they are actual human beings. And yes, if they're asking for research and we're choosing to partake in the research, then yes, there should be some accountability as to what happens to the research. Where does it go? Where does all this information go? Mm-hmm. And I said it earlier today that the research, if you're gathering research for one project, then that research information needs to stay with that project, and it should not be leaked or exchanged unless the intended purpose is for that to be done. But you should do that beforehand. There should be a contract or a consent form that that states that that's what the purpose is going to be, and it should be adhered to. Because what has happened for me, especially, and with other people, sometimes research is used in a negative way. You've got gathered research, but the research that you have gathered, instead of helping, is now harming, because now you've also brought some prejudice into it. Case in point, I had a cardiologist told me that the reason my heart condition was getting worse is because I used too much salt in my food. You don't know that. You haven't spoken to me. You haven't asked me about my diet. You don't know anything about me, but because of who I am and the research that was given to you, you just assume that that's part of my diet. That's just a small example of something with research that could go negative, and preventative measures should be put so that that doesn't happen.
Yes, thank you for sharing. As you were speaking, I was thinking about Dr. Ryan's poem on "I am not your data." Like oftentimes because of previous research, Black and brown bodies are stereotyped into certain what we call chronic diseases. Yeah, and we have to, have a conversation with that individual. Thank you for sharing, Miss Lisa. Is there anyone else that has anything
Yes.
to offer?
Yes, I like to weigh in. T. In one of our previous sessions, we discussed with researchers that a lot of times their funding is so limited until it doesn't have the capacity for the suggestion that I made. Whenever researchers are doing their work, that should be coupled with lived experienced people where a human touch is placed on it. Okay. And that's the balance. Another great part of that particular session was where the funding is being allocated and not properly targeted to really address the medical research objective. And that right there was an incredible find also. So that's what I'd just like to add to Lisa and what she was actually saying there.
And I would like to add on, and T, if you don't
Yeah.
mind, I'd like to add on to
Please
what
do.
Mike and Lisa has said is
Yeah, thank you, Uncle Mike.
saying that, when you don't have the funding and you're talking about having a patient or expert with experience, I don't think I think a researcher needs to start off with that idea, present it to whomever, his lab or whomever, and at that time, enroll, ask, seek out, partner with that patient advocate, that patient with lived experience at the beginning, and then roll into what you need to do so it is understandable later on, and it could be presented for funding or whatever, because I think that should be, I know with a lot of NIH grants, I believe now, you have to have a patient advocate on your grants, or you should. And if not, they're not funded, but also to make sure that that patient is involved in, or that person in the beginning. Don't seek one of us out at the end because you found out one of your qualifications is a check mark if you happen to have or need a patient advocate. I don't want to be your check mark on the end.
Yeah.
I want to be that participant in the beginning.
You
And
said a whole word right there.
Exactly. And also with the funding, I think that even though I am a volunteer, I need to be paid for my time. I need to have something done, whether it's an honorarium, a gift card, take me to dinner, buy me a new dress, some red bottom shoes. No, I'm just joking. But I think the patients need to be given something for their time. And when you're doing the clinical trials, and I'll shut up in just a minute. Clinical trials, that is part of the barriers of Black and brown people with clinical trials is the barrier is they don't have transportation to get there. So why can't you have it close to where they are? Don't make them travel to California to get scans and blood work when they can go 5 minutes down the road and get the same scans and blood work and have them transmitted to California. Also, while they're there 8 to 10 hours a day, they need to have food. Provide them a meal ticket so they can eat. Don't send them there with no food. Just a minute ago, we were talking about food insecurities. Then you're talking about daycare or babysitting costs. Most of them have kids. So who's gonna get them off the bus? Who's gonna get Johnny off the bus? Or put them in daycare? And also pay them for their work. 9 times out of 10, people of color that are in clinical trials have missed a day of work, and they work to keep their insurance because they're sick. So that was my spiel, and I'll be quiet for a minute and let somebody else go.
Thank you very much. And would you like to share anything? And if we have anything that, what I'm hearing you say is that put some respect on it, and what I mean by that, for those who may not understand, is that, honoring, what I'm hearing you say is don't wait till afterwards until you recognize that my perspective and my lived experience and actually participating and going through this. It's interesting. I've been rethinking like words, because sometimes, language is so important. And as we learn more, there needs to be an evolution of the language that we use. We have nurse practitioners, we have different practitioners, and, people who are closest to these systems, and the systems are also within us as well. That's something that I have to level set myself on. But what I'm hearing you say is to honor my time, honor my experience in going through, honor my knowledge, honor my learning, and really taking that person in perspective and their needs to be able to participate. As we're often told, we need more Black and brown bodies to participate in clinical research. But I find that trust is an issue. Ms. Ann, were you going to share?
It's nothing against surveys. I think surveys are good and all, but I feel like in order for you to really find out someone's perspective, especially those that are lived experience, and even caregivers, bless those people who are caregivers, bless them. My daughter's a caregiver and I'm grateful for her. But it's hard to explain to you my lived experience and what I'm going through on a daily basis with just a questionnaire or a survey. You have to actually speak to me. You don't know anything about me at all. And you're coming to me and wanting to know my life and my lived experience. And how can you do that with just certain questions or yes and no open-ended questions? You need to ask me as an individual. And also another thing too is I love looking at research and I love reading research, but I would like for once to know what has come of that research. Did it help anyone? Has it helped the community? Has it helped any organizations? I want to know what has happened. And I haven't really read much of any conclusions on how these researchers have actually worked. So that would be nice to see or know.
I think it keeps I think it keeps a lot of research labs funded. I think it keeps a lot of research institutions funded. These are very great perspectives. Rebekah, do we have anything? Are you guys open to taking maybe a question or two from our attendees?
Bring them on, we got it.
Yeah, our chat is so active. So our participants, our audience is very engaged and excited about this conversation. So I'm just gonna pull them in the order that they came. So this is from an earlier comment that Stephanie made. This is directed to you, Stephanie, but I think anybody on the panel could chime in as well. What ideas do you have for connecting hospital discharge planning to food resources from social services so we don't just send them back to where they came from into a food insecure situation?
Okay, discharge planning. Everybody will tell you, at least the nursing perspective of this is discharge planning starts on the day of admission. So with that being said, and I know sometimes they're in and out, but they have to be assigned like a social worker or something that is continuity of care, I guess. So the social worker is aware of where they come from. Moms may have spoke to them, or they've done one of those checklist thingies and they see that there's issues, have a conversation with mom, with the social worker, food services or something, then have her link to these services that are out there in the community before she goes home to see what is available for them, or send them home and let them know that there will be a 24-hour follow-up. Send the child home with 24 hours worth of food to give mom time to figure out what she can do to go, whether it's to apply for SNAP or some other kind of funding that they, may have resources, food banks or something in the interim of maybe she's just following hard times, So I think just having the link between the discharge and the community, there's got to be a link there that they can have so that child doesn't go back home and bounces back into the hospital for, failure to thrive.
Anybody else on the panel have thoughts on that one? Otherwise, I can go to our next question.
Mhm.
So this one is about the concept of abolishing the current educational system. And our audience member is wondering if this is dumping it entirely and starting a new one, or a massive fix, given that it's a place of last resort for healthcare and food for many families. So that's something I think that we touched on very early in the comments as well. that we want to get back to. Any thoughts?
I'll say again, I'll take this one. Now I'll take part of it. I don't think gutting the whole thing is going to. I mean, you can't gut it and start over. That's for sure. I think there is some ways to tweak it, get rid of some things, make people be more responsible. And I think that's where it might start from. Go in and see. Do a true assessment of the system that you have, a true assessment. Go into the homes and see what is actually there, who actually lives there. Check the schools in which the kids are going to. But I think scrapping the whole thing and starting over, you don't have that much time, and you definitely don't have that much money.
And that's a whole nother conference, right? We just need to have a whole.
Exactly.
Right,
Exactly.
I agree. I
Exactly.
agree, not scrapping the whole thing, but I think it needs a severe overhaul.
Oh, mhm.
Yeah, for those reasons that you just stated right there. That's all.
All right, and this last question is for all four of you. I think you'll all have things to say to this one. This attendee is interested to hear what research questions you four, the panelists, would like researchers to study. So if you could take the researchers and point them in any direction, what do you want them to study?
I would like for them to study for those researchers dealing with dementia and Alzheimer's, because I have such a long experience and journey with it. In the future going forward, I would like for them to not only focus on the patient, but also include the caregiver, because it becomes a point where I was almost pulling my hair out and providing the care for my mother, because the systems was failing. The nursing homes, I dealt with 4 different nursing homes to get some type of relief. And it's almost to the point that you have a breakdown yourself. And my doctor saw it clearly and said, Mike, you are losing yourself in this journey and trying to provide the excellent care for your mother. And I says, but I don't have the support. The only time that I did receive the system to help me was when it became hospice time. And they were like hospice angels, but at that point, you're not able to really enjoy the real quality of life of your loved one, because you're then saying the long goodbye. But I'd like for them to focus on researchers and our funding on the caregiver just as much as the patient that's requiring the care needed.
I'm going to jump in there again. Survivorship. Then I'll quit. I promise. I think researchers need to research regarding breast cancer survivorship. And when I say that, survivorship again starts at the point of diagnoses for breast. I'm talking about with all cancers, but my experiences with breast cancer. So you have the patient that's going through these phases. They go through their initial treatment, and then they end up out here when they're supposed to be quote unquote cured. And we know, as metastatic breast cancer patients, 30% of early stage breast cancer patients become metastatic later on. So not to plant a seed to fear, but to plant a seed to be cautious and be aware. and know your body. So when they're out here and they've finished their treatment and they're on their regimen of maintenance medication, many breast cancer patients feel depressed because it's all stopped now. All the doctor appointments and all the chemo and all the treatment. So they're out here left by themselves now. I'm trying to figure out which way to go. And not only them, but us that are metastatic where treatment will never end. And we just need a place to be able to have some kind of a quality of life, a place to go to decompress. So survivorship is good for all stages, I guess, all phases of an illness, those that are consistent and that will never quit, and those that have stopped treatments.
Good. And my topic would be holistic and preventive care. Okay, let's start at the beginning. Let's try to have, options where instead of giving a pharmaceutical first, let's try maybe adding something to the diet, try nutrition, try, of course, exercise, but try something different. Why do we always have to go for the chemical, which is cheap and caustic? And most of the time, people that are in a different social economical level can't afford the medicine to begin with. So if we have preventative care, perhaps it might lessen the symptoms or even might eliminate some of the chronic illnesses that are plaguing the Black and Brown communities, since we are the ones that are more at a disadvantage.
Elisa, if I may bounce off of what you're saying, and you're right on point. You're right on point. I've found it so difficult, even in providing care over the 20 years. Financially, it will bankrupt you caring for a dementia Alzheimer's person. No matter how much you put aside or trying to resource and pull from here, rob Peter to pay Paul, it will. But I tell you, it's a journey. It's a journey. And I saw some of the comments that I believe that either Rebekah or T will actually pick up. And that's what I have to say in that regard. But I'm 100% on board with what Lisa's saying.
Ms. Ann, do you have
Yeah,
anything?
the chat box is blowing up, Mike, and I'm sure that's what you're referring to. And if for those participants that aren't in the chat, I would encourage everybody to pop it open, talking about this tension about providing hope as opposed to statistics, but knowing that there needs to be some foundation for that. And I think that really is a push-pull, this idea of research and statistics versus, hope and that patient-centeredness, and how do we balance that? There's a lot of talking about prescribing and drug companies and the cost of care and who is profiting. And I'm not going to do the chat justice, but if you have a chance, jump in there because there's a lot of rich conversation. And I think things that we don't explicitly talk about in these spaces, but that I think are in the background of a lot of patients and caregivers, as well as hopefully in the back of researchers' minds as well. If anybody has a specific question that they would like to ask, please put that in the Q&A. I'm trying to keep track of all the questions and comments coming through the chat, but it's going to be quickly buried. So there's a Q&A if you want to ask some questions. We have a few, we do have a few minutes left.
Hey, Rebekah, there is one that's in here that I thought was kind of important. If you don't mind, I'll read it and everybody can answer.
That'd be great.
Okay, someone, actually it was Caroline actually put this one in there. She didn't put it in the question and answer, but wanted to know what the panelists would say the healthcare sector needs to do regarding economic challenges that patients face. given how much money impacts your health, and what should doctors do about patients'
Yeah.
financial challenges?
A great question.
Yes, yes.
Well,
I
we
read-
know,
I'd like to answer that too.
oh, go ahead, Ann.
Go ahead.
Go ahead, Ann.
Well, first of all, going back to the previous question too, what questions researchers should ask, but it's not actually a question, it's a thought. And being that I have a rare illness, no one knows anything about it. So I feel maybe researchers shouldn't give up so easily on these rare illnesses. Even though there's not a lot of information out there, doesn't mean that we don't want to know. So more research on rare illnesses, first of all, for that. My illness does cost a lot of money, especially since I don't know much about it. Doctors don't know much about it. So medication is hard to find. And when we do find it, it is thousands and thousands of dollars. So I am constantly on a monthly basis researching different organizations who might be able to help me with copays that my insurance don't pay. And those copays, even though my insurance pays their part, it's still quite a bit of money because we're talking about thousands of dollars. And also, not only that, if you're on Medicare, such as I am, because due to disability, Medicare will only pay a certain amount of procedures or tests per year. And so when I have reached that limit, which I often do, then I have to find other resources. And it's really hard on myself and my family. And, my caregiver, my daughter, she works full time, and there are days when she has to take time off to take me to the hospital. And we live out in the county, so it takes about an hour and a half to get to the hospital. And that's a lot of driving and gas. So it does get quite expensive. And then you have to worry about what you're going to eat for lunch. And I try to pack mine, and it's just a lot to worry about. It's a big stress factor. So yeah, it's quite costly to have an illness. And that's why my heart goes out to you, Mike, and to any caregiver out there, because it is such a huge, I'm sorry, it's such a huge job. And I'm so grateful for my daughter.
God bless you.
That's all I have to say. Thank you.
Thank you, Anne. As you all were speaking, what resonated to me in this last few minutes, I want to leave us with, and as everyone was speaking, these are the words that bubbled up. I want to take our last few minutes to give a shout out, to give an applause, to give a thunderous roar to all our caregivers out there, to say and use my breath of gratitude for your sacrifices, of your finances, of yourself, of your time, of your energy. I want to say thank you, but I don't quite know if thank you is enough. As I'm listening to my brothers and sisters reflect upon the lived and living experiences that they're in, and the gratitude of taking care of father, mother, brother, sister, lover, daughter. I just want to say to all our caregivers out there, I don't know if thank you says it enough. We'll turn it over to Ann. Thank you all. I love you. And y'all know I mean that. Thank you for your voice and your energy. Blessings.
I think this is my cue to bring us back together. Please join me in thanking all of our final panelists that you see on your screen, as well as in the images and on the slide. Thank you so much, Lisa, Mike, Ann, and Stephanie, and T, and Rebekah. Thank you so much for sharing your wisdom, your thoughts, your feelings with us. This is really the best way that we could have ended this meeting. So thank you. We're going to be transitioning now out of the meeting. Before you go, please, we have in the chat a link to a survey. I know it's a survey, but it's got a lot of places for you to write. So it's not just yes, no things. We really want to know what you thought about this. We did a lot of different things in this meeting that we hadn't ever done. We want to know if you liked it or not. We want to know what we should be doing next and how to support this work going forward and all of your efforts to create a better world for all of us. So please answer our survey. It's in the chat, and then you're also going to get it via email shortly. We also want to let you know that all of the slides have, all of the sessions have been recorded, and we're getting all the slides from the presenters. And so when that's all ready and compiled, we will let you know. It's going to take a little while just because it's a lot of material, but we will get it out to you, we promise. And we're going to be trying to get these amazing sessions out in front of more people because there's been really great stuff shared, and we think more people need to see it. Before we close out, I just want to thank a few people. So if you all don't mind bearing with me on that. First of all, a huge thanks to all the folks that you see on this screen who helped us plan this meeting, some of which you just heard from, some of which participated at other times in the meeting, some of which were just in the background in the planning. We couldn't have put it together without you. This was just such an honor to work with all of you. Thank you so much. And we look forward to debriefing with all of you after the meeting. I also want to give just a huge shout out on my behalf, Laura and Danielle's, the 3 SIREN co-directors, to Yuri Cartier, Dylan Gonzalez, and Alyssa Carey, who were basically like made this meeting happen. They were the powerhouse trio that made this happen. Thanks so much to the 3 of you. I want to thank all of our speakers and presenters that you see here that put work and effort into bringing you the content that you heard. Thank you for giving us so much to think about and learn from. And then I want to thank our funders again. None of this would have been possible without AHRQ, without the Raoul Ward Johnson Foundation, and Kaiser Permanente. So thank you to all 3 of you. And so I want to close us out now, just with a big thank you to all of you for joining us. Tell us what you thought, give us your feedback, and let's keep this work going. Thank you, everybody, and have a really great rest of your day. We look forward to continuing to work together with you. Thanks, everybody.